सबका podcast.
Welcome to the SEPCA podcast.
The podcast for GPs, by GPs, and for everyone working in primary care.
Let's get into today's conversation.
My name is Rosie Hassan. I'm joined with Dr. Mohammed Khalil, a GP based in Glasgow. In today's podcast, we will be talking about clinical reasoning in primary care. It's a skill that's central to good GP practice, but often hard to clearly define or teach.
Absolutely. Thank you, Rosie, for this nice introduction, and welcome for everybody to our new podcast. And you're right, clinical reasoning is a skill we are almost using it every day in our daily practices when we are dealing with uncertainty.
Yes, so to help us break it down, we're joined by Dr. Mustafa Mukhtar, a GP and an educator, and also a TPD in the West Midlands with a strong focus on how clinicians think and make decisions in the practice.
Dr. Mustafa Mukhtar, great to have you on board today. Can you start by telling us a bit about your background and interest in clinical reasoning?
Thanks, Mohammed, and thanks, Rosie. I'm very pleased to be with you. I'm a big fan of the podcast. So I've been interested in clinical reasoning for a very long time. I can't actually exactly remember if there was any one incident that made me interested. But within my career in medical education, one thing I've always been interested in is making diagnosis and those influences. So the idea is that there are other influences than our own knowledge and skills that can affect our ability to make diagnosis and judgment for the patients. And from there, I started the journey through teaching clinical reasoning. Whether it was in my when I was teaching undergraduate in the medical schools and also during our training.
And Dr. Mustafa, how would you define clinical reasoning to a medical student who has never heard the term before?
In simple terms, clinical reasoning is a process. It's how our own brain collect, interpret the data, whether these data from history taken from the patient or clinical examination, how we collect them, analyze them, and make a judgment of what is wrong with the patient and what could be the management for them. So that is what happens almost every time we have an encounter or a consultation with a patient, as you said at the introduction, Muhammad.
Yes, yeah. And talking about consultations, I think as all three of us here are GPs, I think it's really important if you could shed light in terms of how is clinical reasoning in general practice different from in hospital settings?
That's a great question. So it's different in many ways. First of all, in general practice, we are pretty much dealing with uncertainty frequently. And clinical reasoning is a very good tool to handle and embrace uncertainty, because clinical reasoning doesn't just deal with things as black and white, but it does use probabilistic kind of approach to making judgment. The second reason is actually because in quite frequently we don't have access to investigation results as in hospital. So we have to rely on our own judgment. And that is where clinical reasoning plays a big part. So it is different in many ways, but at the heart of it, it kind of follows similar approaches in different places. Even within hospital settings, there are quite some uncertain situations and presentations that would actually require similar degree of depth in clinical reasoning to general practice.
And as you said, GP has been called the specialty of uncertainty. How you become comfortable not knowing the answer at the end of the consultation? I mean, maybe on daily basis, we have one, for example, case, we don't know what's going on and what is the answer. So how we will tackle this?
I think the big thing is to be comfortable that this is part of our day to day, it's part of our job. And this is something that junior doctors and medical students and doctors in their early career might find difficult, because the way we are taught medicine is that every patient who comes in has a diagnosis, and our job is to find that diagnosis. It's like a detective to find out or solve that riddle,
Yeah.
and that is the job. And I think that is a very simplistic way of putting it. When patient comes to us, they do come with stories, they come with worries, they come with undifferentiated problems, and that is a reality whether we like it or not. And once you embrace that level of uncertainty and you accept it as part of our job, is part of the skill that we have to deliver when we see the patient, it becomes something natural that we do. And we also be able to transfer that in an open way to the
Okay, I
patient.
think that's very nicely said. I think what stood out to me from your answer is you said, number one, embracing the confidence, number two, in developing the skill. So I wonder if you could tell us a bit more about, apart from being confident in dealing with uncertainty, do you think there's any other skills that might be important to, develop the skill of being a good clinical reasoner, per se?
First of all, just kind of, I try probably not to go into dividing doctors into a good clinical reasoner or a not so good clinical reasoner, because that gives the impression as if I have got a cutoff, or or it's something I need to become. But reality is, we can all become good clinical reasoners in the first consultation, and in the same afternoon we may not be as good. Why? Because clinical reasoning could be influenced by many factors, and the research and the evidence did show that. For example, if you are overtired, if you are running late, if you are overstretched, if you deal with a difficult patient, or there's an emotional dimension to the consultation, then it may affect our ability to have some more deliberate, in-depth judgment. So it's not different people can be categorized into split of a good clinical reasoner versus not, but it's more of the situation and the context we are in. And I think one skill, apart from being comfortable with the uncertainty, one important skill I think is our ability to have that reflective acumen, being able to think back into that decision that I made earlier. Could I have done it differently? Could I have done it better? And that is how we become better and develop into this. Because crucially, we have this human tendency of doubling up with our own judgment, holding up to it and try to protect it and defend it as much as possible. But we just need to be a little bit humble and question ourselves, and that would help us develop more and more clinical reasoning skills.
I think we've mentioned a lot about, that we touched on the skills, we touched on defining what clinical reasoning is, and where do we get exposed to it, whether, in general practice or in hospital specialty. But to bring our words into action and to help visualize it or understand the concept more, do you think you might be able to give us an example of a consultation where you've used clinical reasoning to help you reach a diagnosis or to be comfortable with where you are?
So when I teach clinical reasoning, one example, I kind of a simpler way, I always bring up this slide of a patient with like a skin condition that could be, for example, rosacea, for example, or shingles, for example. And almost everybody in the room, as soon as they see the picture of kind of a dermatomal vesicular rash, I put the picture up, and as soon as it comes up, everybody would say shingles when I say what is the diagnosis. So, and then I would ask the question, how do you know it's shingles? and then people would pause because it takes them even longer to think about how did they come to that diagnosis, because they actually didn't come to the diagnosis. It feels as if the diagnosis came to them, and it jumps into your mind as soon as you see the picture. As soon as you see facial palsy, for example, or a ringworm, it jumps up to your mind. And that is the basis of one of the approaches of clinical reasoning known as the dual system, where it kind of based on this idea from psychologists that we think in a fast way, that is system one, and in a deliberate, slower way, that is system two. So system one tells you that this is shingles. Now, clinical reasoning is to actually try to deliberately engage system two here and ask yourself, what if this is bilateral? What if this rash has been there for many years? This would make the possibility of shingles less likely. So this is one approach, is try to kind of what if, or just slow down and ask the question, could it be something different? Do I need more information there to challenge this initial assumption? So that is one kind of, there are other different approaches of clinical reasoning, but this is one of them, the dual system method.
So means that is sometimes maybe in an experienced hand, if you reach a diagnosis within a blink of an eye, the risk of getting like a wrong diagnosis may be higher. Then that's why maybe like a junior doctor might take more time, asking more question to reach that diagnosis. Maybe the accuracy here is high, so means that even if you are more experienced, try just to think more before reaching that diagnosis, because you might use system one rather than going to system two.
That is a good question. In reality, the difference between system one and system two, these are not the only thing that would influence the accuracy of the diagnosis. We can't underestimate the value of experience, knowledge, skills. So what we are saying is that it does. If we have the same kind of two clinicians with the same degree of experience and knowledge and everything, but one of them relied on the first impression and the second gave them a little bit of time to consider more, then the evidence tells us that the second one is more likely to have a more accurate diagnosis. But I wouldn't go as far as saying, well, it means always whenever we use system two, regardless of how experienced you are going to be more accurate in your diagnosis than the most experienced one. In fact, there is some work that was done to compare the junior clinicians versus the more experienced one, and that what they found is that system one could be trained to have a more reliable ability to kind of reach a diagnosis closer to a more accurate one. So if you would rather look into use system one, as system one in an experienced kind of person would be, or a clinician would be more reliable than system one in a less experienced. But that doesn't mean the expert always has a right first impression, because experts do have their own biases that are associated with the fact of them being expert as well. So this is another caveat to be considered.
I think that's a very heavy question, but a very heavy answer. Sorry, but I think it was very informative. Thank you for that. So I guess when coming into, I think you mentioned a couple of things like experience and being safe, and that's, I think, the core essence of general practice, because of the flow of the patients we see and the different differentials we tend to see in our clinic. So I think, and that leads me to my next question. You mentioned in a busy clinic day, or even in a normal paced clinic day, I'd want to know what triggers you to slow down and move from from system one to system two, and what spikes that deliberate or analysis during a consultation.
Yeah, so first of all, it's not always easy, because sometimes when we are rushed, when we are exhausted, there is that temptation of using shortcuts. So our brain want to preserve some energy, so we just rely on these shortcuts and pattern recognitions. But I think if we use if you use clinical reasoning as a habit, so whenever I feel like this is my diagnosis or this is my first impression, very quick early in the consultation, I wouldn't write that off completely, but I would just try and challenge that a little bit and just ask myself, could there be anything else that I would have to consider? And I think if it becomes a habit, then it helps us to find ways to mitigate the impact of not using clinical reasoning. Having said that, I mean, it is difficult. It's not always easy. One other way is you can always retrospectively challenge ourselves, and we can delay the decision. So one way that was actually found in some of the research in other areas, not in medicine, but they found that delaying your decision would help you actually reason better and avoid all these unconscious biases. For example, as soon as you see a blood result, for example, instead of making the judgment, just give yourself a little bit of time, go back and review the history, put things in context before making the decision. We also know that we may not be very good at picking up our own unconscious biases, but we are better at picking up other people's biases. So case-based discussion is proven to be good into training ourselves because we are able to see each other's blind spots, and then that would help us improve and become better at clinical reasoning.
Does the patient's agenda sometimes or expectation play any role when you try reasoning through an uncertain presentation?
Exactly, yes, and through a different way. For example, there is one of the commonest biases that System 1 is vulnerable to is what is known as anchoring. And anchoring is when something that may not be exactly related to the problem, if something is mentioned before you make your own interpretation or analysis to the problem, then your brain becomes anchored to that. So as soon as the patient comes, when they start saying, well, I'm just thinking of if I need a scan, for example, with my headache, then your history taking and your questions would be focused more towards ruling out brain tumor, for example, which is good, useful, but it may make you ignore other possible things that may not be directly related to this presentation or to brain tumor. So anchoring can sometimes affect our ability. We might be anchored to the patient agenda. Having said that, patient agenda are always good to address, but they shouldn't be the only thing that we think about when we are trying to interpret the patient's symptoms and presentation.
Yes.
Earlier, you mentioned that Dual 1 and the dual system is one method of clinical reasoning. We'd like to know if there are any other methods that can help us.
Yeah, so there are different other methods. I mean, some people may have been taught clinical reasoning in their medical school, and some of the methods used in medical school, things like pattern recognition, illness script. But one method that I think is more relevant to general practice is the hypothesis deductive method. And what it basically entails is the fact that you, as a clinician, instead of the way medical student takes history and then creates the diagnosis at the end of the history. As a clinician, a GP would start with open questions and then they generate a hypothesis very early on. That hypothesis could be 1, 2, or 3 probabilities or diagnoses. And then the rest of the data gathering would be to challenge this hypothesis, to rule out or rule in any of these diagnoses. And that happens almost subconsciously with experienced GPs. But it makes the consultation more focused and it makes the use of the time more efficient than listing a questionnaire type of long history. So each question is dependent on the answer the patient is giving to the previous question, and that is known as the hypothesis deductive method. So you are generating a hypothesis and you are deducting them with your next and following questions.
Like fast filtering, excluding things.
Exactly, until you reach. And flexibility is very important here because sometimes you might return back and revisit the hypotheses themselves and think, oh, okay, it might be migraine, but it could also be something else not related to migraine. So it does require some flexibility into coming back, revisiting the hypothesis or adding more to them.
Coming to the end of our podcast today, is there any tips or advice you would like to give it to our listeners, Dr. Mustafa?
Yes, I think first and the big thing is that we have to realize that just because we are clinicians and we have the medical knowledge and we spent many years in medical school and in our training, it doesn't make us infallible. It doesn't make us like a computer CPU that is going to objectively process the data that we have in our mind and then gives you the outcome. It's not a CPU, and if we assume that we are the clinician's mind is just like a computer processor, then we would think all what we need is just more clinical information, and then we can reliably generate diagnosis. We have to understand that there is a human and element to this, and this human is vulnerable to all the well-known kind of biases that can affect us. Most of the time, they don't actually cause huge problems, but because we are dealing with patients and sometimes it's a life or death situation, the stake can be high. So I think just realizing that we bring our own human to the consultation would make us humble and try to just be careful when we make that decision. That's my first kind of is the mindset that we should have.
I liked how you stressed on human, especially in a time where we are very much surrounded by AI, thinking, AI can take the job of doctors. But I think from this podcast today, we've reflected on a couple of things around insight, bias, the importance of reflecting on our clinical practice to help improve our thought process when we're seeing patients. Thank you so much, Dr. Mustafa. Thank you so much, Dr. Muhammad Khalil, for joining us today in Sabka's first podcast on this channel. And we hope to see more of you, Dr. Mustafa Mukhtar.
Thank you. Thanks for having me.